What's up, y'all? Dr. Hall, give you another quick video. This is a question I get asked by a lot of primary care providers. How do I manage complications of kidney disease? That is a big question. Well, as a nephrologist, practicing nephrology for about 20 years, I will give you some of the basics of what we do, just to kind of give you some insight. My job with this channel, my purpose, my vision, is to take you from medical knowledge to clinical application. Anybody can read a book, take a test, and pass it. But to take that information that you just got examined in the classroom, bring it to your clinic and take care of a patient, that's a stretch. And that's where I come in. I want you to be like a mini nephrologist. I want you to know how we manage things in the clinical setting so you can, better help your patients, prolong them from getting on dialysis, and just give them the best possible care. So anemia, that's one of the major complications of kidney disease. Anemia of chronic kidney disease is because you have decreased erythropoietin levels. Your kidneys synthesize this, and if the levels are low, you're going to have lower hemoglobin levels because you're not making enough hemoglobin in response to the low erythropoietin, which is the main hormone that helps synthesize hemoglobin. So also, if you're iron deficient, a lot of patients don't absorb iron quite as much if they have kidney disease. That can make you become anemic. So the two main causes of anemia in chronic kidney disease are EPO deficiency and iron deficiency. Well, how do we treat it? Well, we treat the deficiencies. We always treat the iron deficiency first, give them iron, oral or IV. Then we give them erythropoietin to try to help bring the hemoglobin levels up. And our goal, hemoglobin, is 10 to 11. So if you have a patient on iron and erythropoietin supplementation, you want to shoot for a hemoglobin of around 10 to 11 and a transferrin saturation of around 30%. Those are kind of our rough goals that we use to try to keep patients from being too anemic and experiencing symptoms, from being too iron deficient and being cold all the time. Anemia of chronic kidney disease can be a cause of high output cardiac failure if the patient's too anemic. So we're trying to prevent some of these long-term complications. So feel free to treat your patient. If you don't have a nephrologist or a hematologist to help you, this is a way you can treat those patients. Put them on iron, orally or IV. That's Venofer. You can give them Venofer. And you can put them on erythropoietin, either IM, IV, or subcutaneously. The erythropoietin can be given any of those ways. So that's just basically how we treat anemia of chronic disease. Metabolic acidosis is another major complication that we see in CKD. Usually I see a lot of bicarb levels of less than 20, and I usually treat when they get in that 18 to 20 range, because obviously if you don't do anything, it's going to continue to drop because the patient's losing bicarbonate. Their bicarbonate buffering system is not efficient in the kidneys, so they don't actually readily exchange sodium ammonium, which is your buffer, and they lose a lot of bicarbonate and retain a lot of quote-unquote ammonium, which is an acid. And basically the kidneys just can't keep up with the acid load. That's why we advise people to not eat so much meat when they have kidney disease, because of the protein, but also because meat metabolism produces acid. And if you're eating a lot of meat, you're going to have more acid in your body, which causes metabolic acidosis. We usually treat it by giving sodium bicarbonate pills, or we'll give them Bicitra, which is also an oral sodium bicarbonate type agent, liquid form. Or we'll tell them take a teaspoon or two of baking soda 1 and 2 times a day. That's how we treat metabolic acidosis. Also, we want to find out, are there any other causes of acidosis, such as metformin. Now, I know you guys know metformin causes metabolic acidosis, so you definitely want to look to see if your patient's on metformin, because it produces lactate in its metabolism, and that's what produces the acidosis. So just remember to check that. Also check your serum bicarbonate levels in CKD, and remember to check lactate levels, because if the patient's especially on metformin. We talked about when to stop metformin in CKD, at what GFR to stop it. That's in one of our other videos. Check it out. We talk about how the patient develops lactic acidosis and what you as a primary provider can do. We also have built a course and a free webinar below. If you'll click, and hopefully you can see all the case reports. I feel like that's how you bridge the gap between medical knowledge and clinical knowledge, is you just do cases. You read, you passed all your nurse practitioner, physician assistant, USMLE, medicine boards, family medicine boards, etc. But how do you bridge the gap and bring that information to your clinic? And this is what we're doing with our course. This is what we're doing with our YouTube page. And this is what we're trying to teach. So the next thing you want to look at is bone and mineral metabolism, or bone and mineral disorders. A lot of times patients become vitamin D deficient when they have kidney disease, so they don't make enough vitamin D. That causes lower calcium levels, which causes your parathyroid hormone levels to go up. Well, this whole change of calcium, phosphorus, PTH can cause renal osteodystrophy. It can cause osteomalacia. It can cause bone hardening, and osteitis fibrosa, that's bone hardening. And there are a lot of other multiple complexities with renal osteodystrophy. Renal osteodystrophy is kind of the broad term that we use, but for your purposes, you always want to check a calcium, check a phosphate, and check a PTH level, an intact PTH level. Those three things can give you an idea of how the patient's handling their calcium and bone mineral metabolism. If the patient has fell off the scale, so to speak, and the PTH levels are really, really high, indicating they have a severe vitamin D deficiency, which we treat with vitamin D, either oral or IV. If that calcium is low, sometimes you may need to treat with Tums, calcium carbonate, or you can do one of the other calcium supplements. If their phosphorus is high, you need to give them a phosphorus binder. What we normally do is give them Renagel, Renvela, Foslo, which is calcium acetate, lanthanum carbonate. Tums is actually a calcium binder, a phosphorus binder. It's a calcium-containing phosphorus binder, but we'll use Tums. You can give your patient Tums if their phosphorus is high. Tell them to take it every time they eat. And Tums will actually bind the food that they're eating. It'll bind the phosphorus in the food that they're eating and keep their phosphorus levels down. So that's something you can do in clinic. Tell your patient to take a Tums every time they eat, and that'll keep your phosphorus level from getting too high if they have kidney disease. Now, the nephrologists usually catch these type things and pick up on them, but a lot of times, a lot of people don't have adequate nephrology coverage, and so as a provider, primary provider, you kind of need to be aware of some of these complications so you can readily treat your patients and just have a good understanding of what's happening at the metabolic level. The next complication that we see is hyperkalemia. Patients' GFR is low, so they don't quite excrete enough potassium, so the potassium levels are high because of that. Your patients usually they're on an angiotensin receptor blocker or ACE inhibitor. That raises potassium levels, so you got to continue with that. If they're on a dactone or Clarinone, that raises potassium levels. NSAIDs raise potassium levels. Beta blockers raise potassium levels. So there's a multitude of things that can elevate potassium levels. And in a patient with chronic kidney disease, you want to try to keep those in mind and be very selective at the medication that you give, and be very cognizant of how these medications can interact with each other and also cause hyperkalemia. If the potassium is too high, obviously you can stop the offending agent, the medication that you're giving, or if it's a situation where you know this patient has to have this medicine and we need to keep them on it despite the hyperkalemia. What do you do in cases like that? Well, as a nephrologist, what we normally do is we'll put patients on either Keoxalate, which is a sodium-based potassium lowering agent, or Lokelma. That's also a sodium-based agent that binds to potassium ions in the GI tract, or Veltazza. So those kind of like my three mainstays that we use: Keoxalate, Lokelma, and Veltazza. Those drugs will lower the potassium level while helping you keep your patient on the medicine that they actually need, such as the aldactone, or the angiotensin receptor blocker, or the Corindia. So that's how we treat hyperkalemia sometimes in patients who have, severe CHF, CKD, and we really want to keep them on these medicines because we know they're actually benefiting the patient. That's how we'll approach it. And then obviously sometimes we'll just stop the agent because our goal is to do no harm. As a provider, your goal is not hurt your patients. So you always want to keep in mind what we're doing to cause some of these electrolyte derangements. So in review, anemia of chronic disease, metabolic acidosis, bone and mineral disorders, and hyperkalemia. Those are the four major complications we see, the most common we see in chronic kidney disease. And I wanted to give you just a little snippet, just some basics of how we manage it. I hope this was helpful. Check out our free webinar below, and I hope you check out our course. It's basically an online course, 7 modules, quizzes after each module. That will help you bridge the gap from clinical knowledge, from medical knowledge, to clinical application. Thank you for tuning in. We will see you in the next video. Goodbye.